Liaises with radiologists for interpretation of chest X-rays. Outline. Introduction. Normal chest X-ray. Identifying lines and tubes and other devices. Pneumothorax. Pneumomediastinum. Pneumopericardium. Conclusion. Introduction. Interpreting chest radiographs of the critically ill patients who are in intensive care units, ICUs, poses a challenge not only for the intensive care physicians but also for the radiologist. Radiological interpretation is hampered by the bewildering array of line placements in the ICU patient, where incorrect placement is not uncommon, which may not be obvious to the observer without clinical input. The normal chest X-ray. A normal AP chest radiograph of an ICU patient. The standard PA chest radiograph is rarely taken in the ICU patient and is replaced by an anterior-posterior AP radiograph. These radiographs are ideally obtained in the AP projection with the patient to X-ray plate distance of 72 inches, with the patient in the upright position at maximum inspiration. But more often, a distance of 40 inches is used in the supine or sitting position due to the impaired mobility of ICU patients. Identifying lines and tubes and other devices. Tubes, lines, and drainage catheters play a vital role in monitoring and treating critically ill patients. Accurate placement of these devices and monitoring malfunction are crucial. The initial portable chest radiograph plays an essential role in recognizing correct placement and complications. All placed devices should be identified on the preliminary radiograph as a priority in these patients before looking for cardiopulmonary disorders. Endotracheal tubes. Safe level 5 cm from carina, T4, T5 interspace. Minimum distance 2 cm. Nasogastric tube. Ideally, the distal duodenum. CVP lines. Ideally placed between proximal venous valves of the subclavian or jugular veins and the right atrium. Jugular venous placement has lower complications. Swan-Ganz Catheter. The tip is wedged into the distal pulmonary artery. The balloon is deflated once the pressure is taken, and the tip is pulled back to the main pulmonary artery. The tip of the catheter located within the mediastinal shadow indicates correct placement. The thoracostomy tube. The last side hole in a thoracostomy tube can be identified by an interruption in the radiopaque line. Cardiac pacemakers. Cardiac pacers placed within the coronary sinus appear to be directed posteriorly on the lateral chest radiographs. The endotracheal tube. A position of the tip of the endotracheal tube is high at the level of the spinous process of D1 arrow. An incorrectly placed ET with the tip in the right main bronchus arrow, causing partial atelectasis of the left lung. The thoracostomy tube. Chest radiographs are often obtained following placement of thoracostomy tubes to identify their position. It is important to recognize that on a supine AP radiograph, air accumulates anteriorly and fluid gravitates posteriorly. The feeding tube. Radiographs are seldom required for accurate placement of NG tubes and are not used except when the patient is unconscious and there's a risk of placement of the tube into the bronchial tree. Interpretation of atrial blood gases. Blood pH high indicates alkalosis, low indicates acidosis, and normal indicates either normal, mixed defect, or a compensated defect. PaCO2 level. Is it a respiratory problem? If not, look at the bicarbonate level. High PaCO2 with an acidosis indicates a respiratory problem. If the PaCO2 is normal or low, it indicates compensation. Pneumothorax. A frontal chest radiograph showing a large left side pneumothorax causing almost complete collapse of the left lung. Pneumomediastinum. AP and cross-table chest radiograph on a 1-year-old child showing extensive pneumomediastinum. Note that the air is extending to the root of the neck, differentiating it from a pneumopericardium. Pneumopericardium. A frontal radiograph and axial CT depicting a pneumopericardium. Note the surgical emphysema at the root of the neck. Conclusion. To summarize, radiography of lung pathologies common in the ICU patient is discussed, including pulmonary edema, ARDS, atelectasis, pulmonary embolism, aspiration, and ICU-acquired pneumonia in terms of pathogenesis and radiographic recognition of the abnormalities.